tears. And for degenerative tears, you have to work on like a degenerative knee. Like you have to get an scanning X-ray, you have to get an scanogram, you have to see the limb alignment, because the cause of the, or the etiology of that root tear is because of the degenerative joint. So doing an isolated root repair in such cases is going to fail. That patient won't be getting benefited from the pain. So instead of directly going for a root repair, you should do a thorough workup rather than just relying on the MRI finding of degenerative root tears. But for traumatic root tears, going for an isolated repair holds good. Yeah, acute trauma.
Yeah, Dr. Nema.
Thank you. I believe so many experience. I think Anshu is there, Abhishek is there. Usually, for the osteoarthritic patients, mostly in females, when they are in their 40s, they will be coming to you with first symptom of pain over the posteromedial aspect of the knee, which is usually heralds the medial meniscal tear. Now, this is an ongoing debate between the arthroscopy surgeons and arthroplasty surgeons that does it really works? So my question is to all the experienced panelists, Dr. Sandeep Biraris is also there, that what proportion of patients you are able to salvage the knee by repairing the root and at the same time doing the osteotomy? I mean, you are able to delay the arthroplasty, or you are completely able to avoid it, or well say that's what.
Yeah, Dr. Nema, in our OPDs, we see a lot of middle-aged ladies who are slightly obese. They come with a very, very kind of typical history that they were walking, they were climbing down the stair, and they suddenly had a kind of snap, and now their knee is very painful. They are not able to walk. There is slight fusion in the knee. Most of the patients, they settle down. But the patient who are high demand, they are lean and thin, their knee alignment is correct, I think it is worthwhile to repair the root. That is my thought. And if the patient is morbidly obese, they have got lot of other comorbid conditions. I generally conserve them. So this is my thought. The other faculties, they can also express their thought.
I think, Nema sir, you are talking about someone patient who is less than 55, 60 years old, which is an ideal condition for a plasty. So the patients will, after 55 to 60, they are ideal, means you can go for a plasty. But I think we are discussing the patient who is someone like 40, 45 years, 48 years old ladies. They are usually housewives or a moderately demanding patient, not very high demanding patient. And their main complaint is knee pain. And on seeing the X-rays or weight-bearing X-rays, you see there is a slight reduction in joint space. Before planning a root tear or before planning a repair of such tears, always have an arthroscopic view, limb alignment view, and whenever you see a degenerative joint, don't do repair in such cases. If their cartilage is worn off, doing an isolated opening wedge, high tibial opening wedge, medial opening wedge osteotomy, high tibial osteotomy is going to solve her with her pain, knee pain. Yeah. Maybe Anshu will like to add something on that.
Yeah, the patient should not be arthritic for the root repair. Yeah.
So, sir, there are two factors that we need to look at. Number one is meniscus extrusion, and number two is what is the the whether there is any metaphyseal varus or not. If there is, now there are patients in whom you will see meniscus extrusion, but the root is intact. So what has basically happened is over a period of time, the meniscotibial ligament is getting stretched out, the meniscus gets extruded. I mean, I have since I have been very clearly looking at it over the last couple of years, I very rarely see my TKR patients who have a medial meniscus root tear. You need to actually cut out that root, correct? So again, this concept that the medial meniscus root tear definitely always leads to osteoarthritis is probably overrated. Meniscus extrusion is something that is definitely, so if there is meniscus extrusion even with an intact root, obviously there is no surgery to repair that root. But if there is a metaphyseal component of a varus in that knee, then that is what decides the fate of the knee. But yes, I don't have years of experience, but based on the literature that I have seen and my own small number of patients who I have followed up, they do pretty well after a osteotomy. I think root repair is not the game changer. Osteotomy is the game changer.
Yeah, that's true. Okay, thanks.
Moving ahead, I would like to invite Dr. Saurabh Khare on his talk on repair augmentation technique. Then we'll end this session. In the next session, we will take a talk of Dr. Siddharth Jain, Relive radial tear repair. He has just come. Just give him time to relax.
Good morning, respected seniors and dear colleague. Myself, Dr. Saurabh Khare, presenting a talk on meniscus repair augmentation technique. First of all, to discuss the composition of the meniscus, meniscus is basically composed of water and dense extracellular matrix. Water forms are around 72% of the tissue mass, and extracellular matrix composed mainly of type 1 collagen, proteoglycan, and fibrochondrocytes. Fibrochondrocytes are basically the meniscal forming cells, which leads to formation of the extracellular matrix. Biomechanical function of meniscus depends mainly on two things: type 1 collagen and proteoglycans. Type 1 collagen provides the tensile strength, and it effectively transmits the hoop stresses arising from the axial loading, whereas the proteoglycans provide the compressive stiffness, viscoelastic behavior, and load transmission. Now, why meniscus repair is needed? Because the loss of meniscal tissue, whether from the traumatic injury or surgical resection, has been consistently been associated with increased contact stresses, accelerated cartilage damage, and development of the post-traumatic osteoarthritis. These observations have driven a complete paradigm shift in contemporary orthopedic practice from partial meniscectomies towards meniscal preservation surgeries. But there are certain challenges in preserving such type of meniscus, especially the central part of the meniscus. When we come from the periphery towards the central part, the vascularity of the meniscus decreases. Extracellular matrix becomes dense. Because of that, the cellular chemotaxis and migration becomes difficult, and the inner part, the central part, is relatively hypocellular, so it provides less number of fibrochondrocytes, which are the meniscal forming cells, and inhibits the meniscal healing. Apart from this, there are certain challenging biomechanical environment in form of non-uniform stress strain distribution, fluctuating fluid pressure, and dynamic loading. Along with this, certain intra-articular inflammatory environment in form of increased MMP activities and PGE2 concentration, which leads to catabolic event inside of the joint, leading to inhibition of meniscal healing. To counteracting these challenges, there are certain biologic augmentation techniques in form of mechanical stimulation, use of fibrin clot, PRP, stem cell based preparations, marrow venting technique, and biomaterial augmentation. Mechanical stimulation can be done in two forms: the synovial rasping and the trephination. The synovial meniscal junction is a key source of reparative cells and growth factor for meniscal healing. The mechanical stimulation in form of these techniques leads to increase in neovascularization and increase in TGF beta 1, PDGF, and IL-1 concentration. Trephination involves the creation of the vascular access channels that run from the vascular portion of the peripheral meniscus towards the more central avascular area to enable bleeding, clot formation, cell migration, and healing. It can be done in two manners: either anterograde from inside out or retrograde from outside in technique. Synovial abrasion in form of rasping could stimulate chondrocytes in the meniscal surface area to synthesize the specific type of growth factors and cytokines which are responsible for healing of the meniscus. There are certain studies in the past which supports this notion that mechanical stimulation helps in meniscal healing after repair. Next comes in line is fibrin clot. Although the exact mechanism of action of fibrin clots have not been completely elucidated at this point, but it provides scaffold matrix which fills the lesion area. Along with this, it also provides the chemotactic recruitment of the reparative cells, which leads to formation of fibrocartilaginous tissue. We need to withdraw 20 to 30 ml of the patient's blood, and then it is taken in a glass syringe or in a ball, and it is stirred for 15 to 20 minutes, which leads to formation of the synovial tissue, which leads to formation of the fibrin clot. This fibrin clot is added inside of the torn site, which is later repaired by using inside out technique or all inside technique. There are certain many studies done in past which somehow supports this notion that fibrin clot use reduces the meniscal failure rate after the meniscal repair. Marrow venting technique in form of microfracture at the intercondylar region can deliver marrow element rich in mesenchymal stromal cells and growth factor to the repair site, thereby enhancing the healing in avascular region of the meniscus. It replicates the biology of the ACL tunnel drilling. Clinical outcomes are similar between marrow venting and concomitant ACL reconstruction. PRP contains various types of growth factors in form of PDGF, TGF beta, VEGF, epidermal growth factor, insulin-like growth factor. In theory, using PRP to augment meniscus repair appears to be reasonable. But in past, there are two major studies which have been conducted for showing the results of PRP in augmentation technique. One study shows that the clinical outcome was slightly improved in the PRP group, and another study shows the results are equivocal in PRP use group and without use of PRP. Stem cell based therapy uses the bone marrow aspirate concentrate. These MSCs repair bone marrow aspirate concentrate, which are usually aspirated from the proximal end of the tibia, and this aspirate is then injected inside of the repair site. These MSCs enhances the repair by modifying the harsh intra-articular environment and counteracting the elevated cytokines and degradative enzymes by anti-inflammatory, immunomodulatory, and anti-catabolic effect. Previous studies demonstrated that the bone marrow aspirate concentrate applied during the meniscal repair significantly improved the histological healing compared with the repair alone. Last thing is the biomaterial augmentation in form of facial sheath or collagen scaffold to cover the repaired area helps in healing of the complex type of tears which are irreparable such as the double flap, double longitudinal flap tear and radial tears all show the improved healing. These augmentation technique can be further augmented by injecting the fibrin clot, PRP or MSCs inside of the scaffold. The key biologic targets of augmentation techniques include the increased vascularity of the menisco-capsular junction to improve the nutrient delivery and facilitate the inflammatory cell ingress, stimulation of the local cell proliferation, and enhancement of the cell chemotaxis, particularly promoting the synovial cell homing to the meniscal defect, which has been shown to be a major source of reparative cells. In conclusion, the current evidence suggests that the successful meniscal repair will require multifaceted mechanism-driven approaches that integrate the structural stabilization with targeted modulation of the biological microenvironment. Although numerous biological augmentation strategies have been demonstrated promise in preclinical as well as in the selected clinical settings, high-quality clinical evidence remains limited and no single intervention has emerged as universally effective. Further development of these approaches and bioactive materials may improve repair of the currently irreparable meniscus tear. Thank you.
What is the message for beginners if we don't have a ACL, only a meniscal repair? What should be done? What is the minimum that should be done?
So after this talk, we come to end of our session 1. Now, before starting session 2, I would like Dr. H.S. Agrawal sir to distribute mementos to our chairpersons. हाँ सर, वहीं यहीं बीच. So, while the mementos are getting ready, I will, without wasting time, I would like to start our second session. For this session, I would like to invite Dr. Prashant Dwivedi sir as a chairperson. Also, Dr. Vivek Piparsania sir to chair this session. Dheer sir, you remain seated over there. And Ajay sir, you can chair that session. Dr. H.S. Agrawal sir, you are requested to chair this session. These are you remain seated over there. आप बैठे रहिए sir. I would like to invite Dr. Siddharth Jain from Nagpur to give his talk on Relive radial tear repair.
Good morning to all of you. Thank you for giving me this opportunity to talk on radial tear of meniscus. I'll demonstrate a bit of a surgery also. So as we all So as we all know that meniscus are made up of two kind of mainly fibers, the circumferential and the radial one. Circumferential fiber mainly maintain the hoop stress in the meniscus, which actually responsible for the main integrity of the meniscus, which provide the shock absorption and all other functions. So whenever the radial tear is there, it means there are a tear which go from inside to outside, from the inner part of the meniscus to the outer part. So it actually disturbs the peripheral fibers, and it at last it disturbs the integrity of the meniscus, so as the function of the meniscus. The Chahal and all in 2024 they have described the radial tear into they have classified the radial tear into 5 types. 1 and 2 are the partial, 3, 4 and 5 are the complete. 1 and 2 are just in the white zone and the red-white zone. 3 is complete from the white to the red zone. But in the 4 part there is In the third classification, there is no gap is there. The leaflets are completely approximated. But in type 4, there will be less than 3 mm gap, and type 5 will be more than 3 mm gap. According to this classification, they have suggested some for the treatment of the meniscus. It's like in the type 1, you have to just do some reshaping by doing the debridement. In type 2, you can approximate the leaflets by putting some side-to-side sutures. In type 3, definitely you have to put some reduction sutures, side-to-side sutures. And along with that, because it is complete, so you have to put some rip-stop mattress sutures, vertical mattress sutures also. In type 4 again, first you have to reduce it because it's more than 3 mm. So you have to check whether it is the leaflets are getting approximated or not. Then first you have to approximate it. Then you have to put a hashtag kind of suture. That is what they have recommended. In type 5, it is more than 3 mm of distance is there between the two leaflets. So definitely it's a more complicated one. So you have to do some sort of release anterior and posterior to the tear on the meniscocapsular junction, and then the leaflets will be get approximated. You should not give more tension on the leaflets by putting reduction suture and just tie them very on a high tension. First you have to do proper release on the anterior and posterior side. And when the gap is more and you think that there are a lot of tension is there, then you can definitely choose one of more option, that is a transtibial tunnel. Then you can make tunnel through the tibia like the ACL one, or we do in the root repair. That's what you have seen in the previous session also. And you can repair the meniscus through that tunnels also. What kind of gadgets we should have? We can, for the radial tear, it's better to use all inside devices. It may be capsular based or maybe the meniscal based devices. Capsular based device, we have so many options, maybe first, second, third, and now we are on the fourth generation. Meniscal based device, definitely you should have either the knee scorpion Novostitch or the first mini kind of devices. There are various configuration of the suture which you can use to address the radial tear. Coming on to my case, it's a 38-year female, homemaker by profession, history of twisting injury 5 months back. She consulted so many doctors after this. They all suggested some conservative treatment, diagnosed with the ACL mucoid degeneration and the meniscal cyst that was managed with the analgesic and some physiotherapy. Symptom increased for last 2 months. Her symptoms were pain while walking, climbing stairs, or getting up from the chair, night pain, infrequent instability and infrequent locking was there. On the clinical examination, only the medial joint line tenderness and McMurray tests were positive for the medial meniscus. Rest all tests were negative. X-ray was near normal. On a scanogram also, it was normal. If you see MRI, so on this side, you can check the radial tear on the medial meniscus. So coming to the arthroscopy picture. So first we have examined the medial meniscus that was torn near to the root. Lateral meniscus was almost normal. ACL was also normal. No other injury was there, only the medial meniscus was there. So what to do next? Because in such tear, because it was an old tear, so much fraying was also there. So whether to debride it or to repair it, but as we already discussed that every bit of meniscus we have to save because it can lead to osteoarthritis. So minimal freshening was done. So my suggestion is that when you are doing when you are freshening the edges, you should be very cautious, because sometimes we become very enthusiastic and we lost a lot of good substance of the meniscus. So better to do minimal rasping, minimal debridement, and try to save every bit of meniscus. So what I have done, I have taken a bite on first on the posterior side of the radial tear on the meniscus. So it got approximated. Then I put one more knot with a first mini on a more anterior side. Some overlapping you may face, but later that you can debride in the later stage. But because you have to take bite through good healthy tissue so that the bite remain there, it should not cut through substance. Then I have used up all inside device to do a capsular based repair also. So after very gentle cycling, this was the final picture of the repair. There is one more case, 26-year female, history of the slip and fall, 3-month-old injury, no locking, lateral joint line tenderness was only there. Most of the time you can come out with side to side suture and some of the all inside sutures. So this was the tear, which was actually a type 2 kind of tear, which was actually starting from the white zone to the red white zone. It was not going through the red Z zone, so I did minimal debridement and I took 2 side to side stitches to repair this tear. You can use various devices, even the knee lasso device, which is a good one from the which is a very small round at the very distal part, so you can take a bite through that also. So this is the final picture of the repair. So healing normally, if you don't have that ACL or the PCL injury is there, definitely you should increase the healing by either putting the fibrin clot or doing some synovial aberrations, or you can do some microfracture over there. And I normally use, if there is no ligament injury, I normally use 3 sorts of PRP injection, first on the 2nd, 4th and the 6th week post-operatively. So there is a very good study which we all should go through, is by the child. It's in the 2021 in Journal of Arthroscopy. It has clearly they have shown the result that there is no significant difference in the clonogenicity of the isolated cell from all the 3 zones, so that we have all kind of mesenchymal cells in all the zones. Even the white zone has more mesenchymal cells and more vasculature. So the clinical relevance of this study is that even in the white zone, if you do a proper repair and you augment it, it is there are high chances that it can also get healed. Debridement of the radial tear has been shown to result in an inferior biomechanical outcome, perpetuating a meniscal deficient state, which can lead to knee osteoarthritis. Thank you.
Sir, in the type 5, you were able to approximate the edges, but sometimes whatever we do, we cannot get the flaps close to each other, and we end up debriding. There's a big gap. In such cases, do you recommend we fix it to the meniscocapsular junction?
No, if
Suppose
you
we
read,
cannot get the, we cannot close the gap.
at that time, what you can do, you can release somewhat on the meniscocapsular junction on a posterior side and anterior side. Then you might be able to do that. But if the gap is very large, it's like more than 5-6 mm, then definitely you won't
So
be able
you
to.
recommend fixing it to the doing the transtibial, or fixing
Yeah,
it
it's
to
better
the
to do
meniscus
better to do transtibial then at that time.
and anchor it wherever we are getting a hold.
No, you have to do, yeah, minimal gap you can leave, but anyway, whatever minimal gap you can achieve, that you have to do. And most of the time you have to try to approximate it properly,
So again, we are looking at healing, side to side healing.
side to side healing.
Otherwise, the hoop stress is not managed by the meniscus, you say.
Definitely.
Thank you.
And so more important thing is that when you have that kind of tear, if you are having a more than 5-6 mm, mostly by the time the cartilage may be gone off. If you have that kind of large tear,
Sometimes we see it is already separated from the capsular area. You're asking me to free it around the capsular area so that we can
Yeah,
approximate the. Sometimes it is in tatters. So by the time you debride it and it's already free from the meniscal side, sorry, the capsular side. So there's a appreciable gap. I think somewhere around 10 mm gap. So in such
10 mm
scenarios,
is very large. It's
so
very
what do we
difficult
do?
to manage by that.
So what do we do?
Then I think you need to do
Really?
that Bachas's technique. I think that's some hamstring sort of thing tendon you can put there.
That is side to side also and transtibial.
Yes, and that you can fix in the capsular side also.
So I wanted to know if there is any easier hack to it.
No,
Because I have got caught in a couple of situations. I ended up balancing it.
If
or
the
excising.
gap is large, then definitely you have to fill that gap with some sort of collagen, which may mimic a meniscus. So in that case, either the hamstring, either the gracilis or the extremity, you can make a layer of that, and then you can put in between. Or normally Dr. Bacha put through the meniscus substance. You can just repair it with the capsule, and you can make a transtibial tunnel, and then you can tie both the sides.
Thank you. Very nice demonstration of the sutures.
Thank you.
Good videos.
Now, I would like to invite Dr. Siddharth Kumar on his talk on the discoid meniscus.
Good morning to all the delegates here. I'll be speaking on the discoid meniscus. As we all know, the discoid meniscus is a congenital abnormality, and which is due to the persistence of the discoid shape from the intrauterine stages of life. The reported incidence of lateral discoid meniscus ranges from 3% that is seen in the Western countries to about 13% in the from the Japanese literature. However, the true incidence is not yet known. One might be surprised to know that the discoid condition may also affect the medial part of the meniscus. The incidence of that is much more rarer. So most of the patients with discoid meniscus tend to be asymptomatic. However, the most common age of presentation is the young adolescents. They usually present with pain, effusion, some clicking or snapping, a sensation of giving away. Some of them might present with locking-like symptoms. It is important to note that many of the patients who present with these symptoms, the meniscus is either unstable or there is an associated tear. There is a high degree of bilateral involvement in these conditions, which may be as high as up to 97%. Hence, it is recommended to always investigate the asymptomatic contralateral side as well. Many of these patients may be associated with cartilage injury and of female gender, higher BMI, persistence of symptoms for more than 6 months, and high activity, high impact activity, especially predisposed to such cartilaginous injuries. The architecture of these discoid meniscus is much different from our regular meniscus. Here, the collagen fiber system is much more disorganized, and it is associated with poor vascularity of the inner areas. And there is also a lack of peripheral anchorage. All these predispose the discoid meniscus to more tears. The Watanabe classification is the most commonly used classification for these menisci. The type 1 is a stable meniscus which is complete and covers the entire lateral tibial condyle. The type 2 is again a stable and partially covering the lateral tibial condyle up to 80%. Type 3 or the Risberg variant is the unstable type, and it is devoid of meniscotibial attachments. Hypermobility is a characteristic of such discoid meniscus, and it may be present in both complete or incomplete incomplete discoid menisci. The radiographic signs may be subtle, and it is one might suspect a discoid when we see a large lateral joint space. MRI is the diagnostic, but one should remember that even MRI may miss some incomplete partial discoids. Silverman's criteria is an important criteria that have been defined for diagnosis of discoid menisci. Meniscus width or maximum meniscus width of more than 15 mm, or a ratio of the minimum meniscus width to the maximum tibial condyle width of more than 20 is considered to be diagnostic. Other signs, including the bow tie sign, may be helpful in diagnosis, where one can see the continuation of contiguous anterior and posterior horns in consecutive 3 sagittal images, or the axial cut, where one can see the tibial more than 80% of the tibial condyle being covered by the lateral menisci. The Risberg variant also is important to diagnose the Risberg variant, which is the unstable type. One can see a hyper intense signal in between the posterior horn of the lateral meniscus and the capsule, or a subluxed posterior horn of the lateral menisci. Asymptomatic discoid meniscus are managed conservatively, and they need regular follow-ups. Even symptomatic discoid meniscus with mild symptoms are initially managed conservatively. Only those which have persistence of symptoms, or the symptoms when they are severe, such as locking, one should offer surgery. The most commonly done surgery is arthroscopic saucerization, which involves a partial meniscectomy to reshape the menisci. Prophylactic surgery for an asymptomatic contralateral knee is generally not offered. Symptomatic discoids which are associated with tear are managed in the regular fashion, like we manage all our tears by inside out or outside in techniques, depending on the location of the tear, and biological augmentation can be done along with it. So this case where one can see the large discoid meniscus covering almost the entire of the lateral tibial condyle, one should proceed with an arthroscopic punch, initially targeting the body and then working anteriorly and posteriorly to reshape the meniscus. One should not directly go in with an arthroscopic shaver, as that might we might end up in doing a complete meniscectomy. We shouldn't use it intermittently to clear up. That the aim should here be to preserve around 7 to 8 mm of peripheral rim of cartilage, peripheral rim of meniscus. As one proceeds with the meniscectomy, a tear might reveal itself, and depending on the location, one should go ahead and repair those tears. The most common type of tear that is usually seen is this kind of a horizontal cleavage tear. the tear site is rasped, and the mouth of the tear is closed using all inside repair technique, using an all inside suture passing device. Multiple such sutures are employed. The body part was managed by an inside out technique. So, many of these discoid meniscus may also be associated with peripheral rim detachment, and which is again managed like as in this case using an all inside suture device. So there are certain other types of tears that can be managed again by the subtotal meniscectomy, or it can be augmented using the thicker portion of the discoid. Open techniques have also been described. Centralization procedures with or without saucerization have also been described in literature. Complications of most of these discoid surgeries are progression of osteoarthritis, increased risk of re-tear, and rarely osteochondritis dissecans of the lateral femoral condyle. Recently, meniscus allograft transplantation has also come into the picture with the promise of a reduced incidence of future osteoarthritis development. And so all in all, to conclude, treatment of discoid meniscus is still largely conservative. Mild symptoms with or without tear can be managed conservatively first. Arthroscopic surgery, when performed, one should always aim to preserve the meniscus as much as possible, aiming for a 7 to 8 mm of peripheral rim. Repairs are preferred over complete meniscectomy. The results of surgeries are quite good. However, the clinical outcomes tend to deteriorate with time, and there's a dearth of level 1 or level 2 literature comparing the different types of surgical techniques. Thank you.
Good presentation, Dr. Siddharth. I have a very basic question. I want the seniors to tell me. In some cases of discoid, when it is not a complete discoid, it's not covering the entire condyle, the patient has done well for almost 25 years. Then he has a tear of the discoid. That's why he comes to you. So if somebody like me who's not so meticulous with his all inside, is it wise to just repair the discoid and leave it?
That has been described in literature.
It's a simpler procedure.
Yes,
so
without the saucerization, only stabilizing the tear part of it. Most of the papers do describe saucerization along with the repair, because leaving a larger thickness of meniscus predisposes them to re-tears. So that is the whole idea of.
Is it like if a person comes to you at a very young age with discoid meniscus tears and symptomatic discoids, you should try to do saucerization? If somebody is coming very late, you would
Yes.
want to leave it?
Yes, because it has been seen that if you leave more of a meniscus intact, there is an increased chance of a re-tear, and if you leave too little of meniscus, then there is chances of osteoarthritis in future.
Just one more question, Dr. Siddharth. If you have an incidental finding of discoid meniscus while doing your ACLs or something, so what you do, what we will do? There is no tear in the discoid meniscus, but you have noticed the lateral meniscus is a discoid. So what you will do?
I usually reshape it. I would like your opinion on that.
Yeah.
When I am doing an ACL along with it.
presentations of discoid meniscus are a patient will tell some snapping into the knee. It is rarely found with concomitant ACL tear. So mostly young patients, 20, 25-year-old, more common I believe in females. So they will come with a snapping sensation into the knee. And the second most common presentation is he would have been some enthusiast would have without any symptoms or without anything, there is maybe a sprain into the knee and some enthusiast as usually happens would have advised an MRI and there will be a finding by the radiologist that the patient is having a discoid meniscus. These are the two most common presentations. I believe if it is asymptomatic and patient is having ACL tear, why to touch it? That's what I'll say for the discoid meniscus. If it is a incidental finding during surgery.
Sir, many a times what happens is, since the discoid meniscus is a congenital problem, patient learns to bear with it the snapping problem. So he or she thinks that it is a normal finding. And I have encountered few cases where in arthroscopy, I have found a discoid meniscus while doing an ACLs. So what I do is, I just do a saucerization, rest, nothing repair like that because they don't need repair because there is no horizontal cleavage in tears type of that in asymptomatic discoids. But going inside, आया हूँ कुछ तो करके जाऊंगा sort of a thing. Anshu, you are.
That is crime master Gogo. आया है तो कुछ लेके जाएगा. No, but asymptomatic discoids encountered during scopy should not be touched. Saucerization is now getting out. We have good data from Japan and Korea that meniscoplasty should be avoided. If there is a peripheral rim detachment, just reattach the rim and leave the rest of it. Don't do a meniscoplasty, what was called saucerization. So this is, but definitely asymptomatic discoid encountered during scopy, don't touch.
Yeah. Hello, Abhishek. Abhishek.
Yes, sir. Yes, sir.
Whatever you do, the discoid meniscus is abnormal meniscus. Whatever you do, the patient will have little compartment osteoarthritis in the later time. So if you do this operation, you do the repair after 10-15 years, they will have some problem.
Yes.
Whatever you do. It's not a normal meniscus at all.
So it is a good learning point for all of the young surgeons out there. Not to touch any discoid meniscus. Don't be like a crime master Gogo like me. Just leave that discoid meniscus as such and just do your ACL reconstruction. So that's how we learn, no? And that is what this course is for. Thank you, Dr. Siddharth. Thank you. Now I would like to invite Dr. Ravi Mohobia for his talk on when I would not repair a meniscus. Very interesting talk for young surgeons when they should not try to attempt to repair the meniscus.
Thank you, sir. Good morning, everyone. I am going to talk on the when not to repair meniscus. There is zones of the meniscus. One outer zone is red zone, that is well vascularized. Mid zone is red-white zone, intermediate vascularity. White-white zone, it is avascular. Peripheral 10 to 30% part is vascularized. It is supplied by the genicular arteries. Central part is avascular. Healing potential depends on the blood supply. This is showing the blood supply of the meniscus. Type of meniscus tear. There is longitudinal tear, bucket handle tear, radial tear, horizontal tear, and complex tear. This picture is showing different types of the tear. First of all, we will see the indications of the meniscal repair in the young patient in acute tears, in tear in vascular zone, longitudinal vertical tear, and associated ACL injuries. We go for the meniscal repair. Indication for the conservative treatment of the meniscus tear. Usually in the degenerative tear, usually in patients more than 40 years, stable vertical tears less than 5 mm, a small radial tear less than 3 mm, patients without significant mechanical symptoms like blocking and clicking. When not to repair meniscus. If there is tear in the white zone, degenerative tears, complex tear, poor tissue quality, elderly patients with low demand, and grade 3 and 4 osteoarthritis of knee. Indication of the meniscectomy, frequent complaint of popping, locking, clicking, sensation during ambulation, symptomatic patients in which meniscus is not repairable. Goal of partial meniscectomy, to remove only unstable torn tissues, smoothing the meniscal edges, saucerization, preservation of the vascular rim, preservation of the functional and healthy meniscus. Indications of the meniscectomy, irreparable tears, complex tear, tear in white zone, and failed repair. If meniscus repair failed more than 2 times, so usually we go for the meniscectomy. Meniscectomy disadvantages, cartilage overloading and aggravated degeneration. Contraindications of the meniscectomy, patients who have reparable tear pattern in vascular zone of the meniscus, patients with significant osteoarthritis on imaging, typically do poorly with partial meniscectomy. In these patients, knee arthroplasty is commonly the surgical procedure of the choice. Decision making, meniscectomy or repair or conservative. First of all, there is a percentage. If patient is young, go for repair. In older patients, often needs meniscectomy. Tear location. In the red and red white zone, we should go for repair. In white zone, meniscectomy is preferred. Tear pattern. In vertical longitudinal tear, go for repair. In small radial tear, complex or degenerative tear, go for meniscectomy. Stability. If if meniscus is stable, it is not coming in the joint, so we can, in stable meniscus tear, we can go for conservative treatment. In unstable and symptoms such as locking, we can go for surgical management. Thank you.
Is there any time frame after a bucket handle tear that you would think that we should not be repairing it? Bucket. A good red, white, or chunky bucket handle, but it has been old. I have had some patients who came after a couple of years of injury. So, is the time frame of any importance?
Sir, actually, there is no such a time frame. If it fails more than 2 times, so we can go for meniscectomy. Otherwise, we have to attempt next time to repair it.
That's a very interesting line. I have sometimes failed in a single surgery. I have failed twice or thrice. So
Okay.
I count that also as a 2 times failure. What I'm asking is sometimes the tissue is just not
Yes,
good.
sir. If tissue, yes, sir.
It looks like a scarred. It looks like a scarred
Scarring,
gelatinous.
yes, sir. If tissue quality is good, we can.
If the bucket handle is not reducible, then what you will do?
What do you mean by a non-reducible meniscus? There is nothing which is non-reducible.
Thank you, sir.
Call for help.
Thank you, Dr. Ravi. Now I would like to invite Dr. Dushyant Chauhan. Yeah, Dushyant, please. He will talk on rehabilitation after meniscus repair.
Good morning, everyone. My topic is rehabilitation after meniscus repair, and our focus should be on biology, biomechanics, and return to sports. When do we allow full flexion after repair? Is rehab is based on biology or it is time based? And we have some new protocols that will challenge the conventional protocols. Why rehab matters? Because always surgery failure is not a surgeon failure. It is most of the time rehab failure. Failure is due to mismatch of biology and loading. Rehab determines final outcome. Biology of healing, if it is in the red zone, then high healing potential. If it is in the red white zone, then moderate healing potential. And if it is in the white zone, then poor healing. Healing takes almost 12 to 16 weeks. What is the biomechanics of rehab? Deep flexion increase posterior horn stress, rotational increase shear force, and axial load plus flexion maximally produce stress on the repaired part. So there is a chances of failure. What is the key controversy? Early versus delayed weight bearing depend on the tear type. Simple tears, we can go for early weight bearing. If it is a root tear and a radial tear, then we should delay the rehab. We should always follow tier specific rehab. Like when there is a longitudinal tier, faster progression. So we can go for early rehab and weight bearing. If it is a radial tier, we should delay loading and weight bear. If it is a root tier, then strict not bearing, not weight bearing protocols. And if it is a complex tier, then we can go for conservative rehab. General guideline is cryotherapy for 72 hours, no submerging knee for 4 weeks, use crutches for 6 weeks, and follow-ups in 10 to 14 days. There is 6 phase in meniscus rehab. Phase 1 is from 0 to 2 weeks. The goal should be protect knee, control inflammation, brace in the locked positions, and the exercise that is advisable is knee ankle pump, squat sets, and leg raises. In phase 2, that is from 2 to 6 weeks, maintain extension is very important. Increase flexion gradually. Brace in the 0 to 90 degree, and exercise that is advisable is heel slides, hip strengthening. In phase 3, that is from 6 to 12 weeks, restore gait, progress weight bearing, and exercise like cycling, treadmill, and step ups is advisable in phase 3. Phase 4 is from 12 to 24 weeks, and the goal is to strengthening and endurance, start jogging, and balance and plyometric exercise is advisable. In phase 6, that is from 6 months to return to sports, it is a agility drills and sports specific training that is personalized. And what is the criteria to return to sports? There are 4 criteria. The first one is a quadriceps strengthening should be more than and equal to 90%. Full range of motion should be there. No effusion and hope symmetry should be there. On the basis of these 4 criteria, we can ask the patient for the return to sports. Common mistakes in rehab: early deep flexion, that is very dangerous. Ignoring tier type protocol for all patients, it should not like all for same protocol, and no return to sports testing. Evidence-based insight: accelerated rehab safe in selected cases, root repairs need protection, criteria-based return to sports is superior. And limitation of current rehab: no universal protocol, tier variability, surgeon preference bias, compliance issue, and limited return RCT evidences. Take home message is rehab should follow biology, not time. Respect biology, not timeline. Meniscus rehab should be personalized, not protocolized. And return to sports should be the criteria based, not the calendar based. And by this, we can protect, progress, and perform. Thank you.
Thank you, Dushyant. By this talk, we'll come to the end of this session. Now we'll move ahead with case-based panel discussion. Till the time we are getting ready with the panel discussion. So, do you have any questions for our faculties? I would like to request all the faculties right from first and second session to please be ready for the panel discussion. Till the time you can load this. Dr. Sanjay Gile, Dr. Naresh Gaul, you can please come forward. And sit over here. Yeah, you can come, Naresh, please. Anant, I think has gone for the room. HS sir is over here only. Sir, you can come over.
Dr. Siddharth, come forward. Dr. Naresh. Dr. Naresh, come.
Dr. Naresh, you can come forward.
Come forward, please.
Yeah, you can. Get it. Yeah, you can come forward.
Dr. Naresh, please come.
Dr. Naresh, please come. We are bringing more chairs. Farooq, chair लगवा दें, 4-5 चेयर. ज़्यादा नहीं लगवाना, 4-5 लगवाना.
So we'll start. Time बचाना है ना, लाइव सर्विस रेडी है ना?
लाइव सर्विस रेडी. स्किन मार्किंग चल रही है.
कितना टाइम होगा तो?
हाफ एन आवर में फिटिंग.
कौन बच्चे? दुष्यंत, come forward. सिद्धार्थ आया.
रवि मोहबिया. Dr. Ravi Mohabia. Okay, I will just call you.
So good morning. We'll start. Okay. वहां बैठा तो ज्यादा बेटर है. वो अंशु उठा लिया ना. हाँ. वो पास बैठा. हो गया ना. हाँ.
Abhishek, only 5.
Yeah, we have 5 plus 3.
5 plus 3. Okay. So we'll start. So for first case, this patient, 15-year-old male, he had a trauma 1 year back while playing basketball, and he presented to me with a acute locked knee. He had multiple locking episodes, and rest examination is normal except the lateral joint line tenderness and the back malaise. So this is the MRI of the patient. So this patient has a clear cut, it's a bucket handle lateral meniscus tear. So I'll start with HS sir. So how often you see the lateral meniscus bucket handle tear in your practice, and it's a 1-year-old injury. So how will you plan and what you're thinking?
The locking of medial meniscus,
It's lateral meniscus bucket
is
handle.
more common. Lateral meniscus is rather rarer, but we do see in our practice. And once you see the knees locked or has got a history of frequent locking, we have to treat this patient. And treatment is, you have to do the arthroscopy, you have to reduce the meniscus and do the fixation. The choice of fixation can differ. You have to have everything in your armamentarium. When you are dealing with a chronic kind of a bucket handle tear, you have to be ready for everything. Then only you are possibly able to repair.
See,
And you have
most
to
of
be ready
the
for
time,
the other injuries which may be concomitantly found there. That is my thought.
most of the times lateral meniscus bucket handle tears will be presented in sports person which pivoting type of sports, especially like football, basketball.
Yeah.
So seeing in this kind of injuries, especially keeping a basketball player in mind, so this is it has to be treated with proper fixation of the meniscus.
So do you will counsel the patient that it's already 1 year. So is there any chances that it's not repairable or
Yes.
it's not reducible?
Yes, but no. Only thing we have to keep in mind whenever we are dealing with a lateral meniscus. Lateral meniscus is the
prognostic indicator for developing arthritis in a young. So you have to you have to address all the possibilities. Tell the
To repair
patient tell the patient about repair. In very rarest of the rarest scenario, if the bucket handle part is completely torn and kept in the notch, then we have to remove it. Otherwise, repair.
Yeah. So this is the arthroscopy. So it is reducible. There is no doubt about that. And so how will you repair it, Dr. Siddharth? So what is you will use inside out, outside in, all inside, or mix hybrid thing?
For the lateral meniscus on a posterior side and on the body side, definitely all inside device, capsular based. And if it is coming up to the anterior side, then I can use a outside in device.
Okay. So no inside out. No inside out for you for lateral meniscus.
Lateral meniscus,
Never.
yes, yes.
Okay.
Right.
So anyone they use inside out for lateral meniscus repair? So if you are doing an inside out lateral meniscus repair, you will take a safety incision or not? Definitely. Like in medial meniscus, we are doing without a safety incision now. So anything anyone wants to add in this case?
I think when you are using a all inside device, definitely the length of the needle you have to keep smaller.
Yeah,
than the
HS sir
medial
already
meniscus.
mentioned that.
Yes, you have
That
to
you are
keep it
using
like-
the anterolateral portal, the length should be less than 18. So what I will show what I did. I always do, most of my cases I do inside out repair. In lateral side I use the safety incision. So in this case also, I did inside out. So because I can use as much as sutures that I can, and it's a very strong repair. So here you can see anterior to the popliteus, I have passed 3 sutures, posterior in the femoral side, 3-4 sutures. Then I will use it on the tibial side also. But the important thing in lateral meniscus is the needle you should always see when it's coming out, because it's a very risky area. If your safety incision is not perfect and if you can't see the needle, then you will end up in trouble. So if your team is good and you're doing it routinely, so lateral meniscus inside out repair is as good as a all inside. The advantage that we know cost is one of the factor, and the repair is much stronger than a all inside, that I will say. So anyone want to add anything, Dr. Dushan?
Sir, the size of the incision is same for the medial meniscus, that safety incision?
Medial meniscus inside out, we are not using safety incision now. At the end, we keep a small incision to just tie the knot.
I will keep a CTVS or a repair surgeon with me in the backdrop, because unlike the medial meniscus, in the lateral meniscus inside out repairs, the risk of vessel injury is considerably more, as Dr. H.S. Agrawal showed in that video initially. So the risk of vessel injury, particularly because you are having a bucket handle tear and you are never sure till where it is ending up posteriorly in the posterolateral corner. And there, the trajectory of the needle in particular is very much at risk to involve the vessel. I have injured one.
Sir, lateral meniscus safety incision is much easier than the medial one.
No, that's correct. Safety
And
incision is
before you putting
it's
any
undoubted.
needle, you have to
Yes.
just feel it, that
Yes.
you can feel the needle enter to the spoon.
Right.
Then
right.
you're sure that you're not going to harm any vessel.
Right. Right. But since I injured one, I thought it's better.
I'm more
that I
confident
should
in inside out
share
in this
it.
patient than all inside device.
Right.
But
Right.
Do you have
Thank
to
you.
do something about the vascular injury, or you just pricked it and you withdrew it?
I had to call the plastic surgeon and then subsequently turn the patient prone, and then subsequently they repaired. Yeah.
So I feel the space in the lateral compartment is so narrow that inside out is
No,
easier.
yeah, that's correct. But actually, it's not the surgeon's mistake. It's like the inside out trajectory. You do not have a very strict
You're not very-
control.
You're not
So
very-
that is the reason, one of the reasons that there is a high risk of injury, not in the using the the medial meniscus. You can, of course, from because there
Actually,
it
your
is
comment
relatively
on
safe.
inside out lateral meniscus repair.
Yes, that's inside out lateral. That's what I'm saying. That I will be relatively wary of repairing the lateral meniscus inside out, particularly a bucket handle tab, where you need a suture every 4 millimeters, and going particularly over the posterior aspect, I'll be a little bit more cautious.
He wants to.
I think if you see Preetham's video, all his sutures are anterior to the popliteus except for one at the back. So I think anything anterior to popliteus in no way harms any neurovascular structure. I will stick my neck out and say you actually don't need a safety incision if you are anterior to popliteus. You can later retrieve them. But what he's done beautifully there is he's put a retractor. If you can see that spoon thing. So yeah. So I use a Henning's retractor. If you have a Henning's retractor, this suture which he's putting now and this one which he's putting now, which is posterior to the popliteus, will go and hit that retractor and it will deflect. So the danger is not to the vessel, the danger is to the CPN. Because
nerve injury is more common than the vascular.
Yes. Yeah.
Hello. Sir, how you keep the position of the limb in this case
So it's
to
a
take the
figure of 4
safety
position,
incision?
like you do lateral meniscus repair.
Okay.
So that your assistant will take a stool, he will sit down, and the table height should be high, and you're holding the cannula.
Yes.
One assistant is putting the needle, and one is retrieving the needle.
Okay.
So we'll move to the next case. So this is medial meniscus, medial side, 20-year-old male, twisting injury 15 days back. It's a classical ACL and bucket handle of medial meniscus tear. So already there was a presentation on that. So what different in medial meniscus bucket handle tear? HS sir? So what you do? You do always inside out, all inside, hybrid fixation,
I always do
safety incision.
inside out. For the medial meniscus, 100% inside out.
So everyone do all inside out for bucket and medial meniscus or any different? And what about the?
I take posteriormost and I use all inside. The body part is the inside out, but for the anterior part, if it's ending, it is very, very difficult to do an inside out unless you have a zone navigator type of.
Yes.
So for that, you need to do a outside in type of repair.
So, but if you have a zone navigator, you can reach till the anterior part very easily.
If the bucket handle is extending right up to the anterior root, somehow you have to use an outside. So you need to be work with all three types of repair if you are planning for a bucket handle.
So you guys use safety incision or not for the medial side? Safety, yes or no?
I use that.
Always.
I also use because without safety incision, when we tie that thread, that is not stable. It's my experience. Whenever I have not used safety incision, then the fixation is not that good.
So, but at the end, you're taking an incision to tie the knot over the capsule.
But the point is that if we are putting two sutures from two different places and we are joining two, it's like sometimes it's more than the safety incision. The length of the incision is more than the safety incision. So I always use safety incision. But just I wanted to ask you, sir, how you will tie without safety?
That I'm going to show. So for medial side, I never use any. Initially, I used to use the safety incision. I've stopped it. And at the end, after passing all the sutures, I will take an incision. So one thing I want to show. So about the saphenous nerve. So how many of you encounter post-op saphenous nerve compression? Patient have symptoms after a hyperflexion of the knee. They will have tingling, numbness in the legs. So your experience on that?
Yeah, it is quite frequent.
So how to avoid that? What you do to avoid that?
It's very difficult. I mean, you have to really dissect the saphenous nerve. Many times it comes in the trajectory. It comes when you are taking the graft. The another point I wanted to make: whenever you are tying the sutures, the knee has to be either in 20 degree of flexion or full extension. On medial side, if you tie in the flexion, the flexion is going to end up in the flexion contracture. So this in the medial side. Lateral side, it does not matter. But on medial side, you have to keep the knee rather in extension when you are tying the meniscal sutures.
So it will matter important in your saphenous nerve.
Saphenous, yeah, saphenous nerve position is there. It is
So Dr. Siddharth, how you tackle the saphenous nerve part?
I always take safety incision. So
Okay, you take the safety incision.
always go beneath the semimembranous.
Okay.
That way, I don't take a safety incision. I take a random bite, but before tying a knot, always dissect out, and many times it is very difficult to identify the separate nerve. So always don't tie the knot above the semimembranous muscle. Always go beneath the semimembranous muscle, directly on the capsule. In this way, you are very much sure.
But sometimes one suture is anterior to the saphenous nerve, one is posterior to that.
Always go beneath the semimembranous. You have to lift the semimembranous. If there is a muscle part of the head, then you have to lift that and directly go and directly take both the sutures from below that and tie the knot on the capsule.
So recently, what I have done, most of the time we can see the saphenous nerve. Once you put the incision, it's in front of there. So if you'll see, you'll dissect it. So either you can pass the suture behind it and tie it, or you can excise it also if it's coming in between the sutures.
So I actually don't take a longitudinal incision. I take a transverse incision because that is along Langhans lines. And if the nerve is getting entrapped, just retrieve it, pull the nerve on either side and then tie it off. And almost all of them have some amount of paresthesia. I mean, 80% of my ACLs have paresthesia in the anterolateral side.
It could be because of the hamstring retrieval.
It could be anything, but
the
80%
problem
have
is
it.
in hyperflexion they have that severe paresthesia sometimes. Very few patients.
That is if there is nerve entrapment.
That is entrapment.
Correct.
Then you go back in, take the saphenous nerve, exercise.
Then you refer
That
to a
I'm doing,
neurologist.
initially only. Okay. So third case you want to?
Sir, just
What you do for if there is a nerve entrapment, what you will do?
I have done one on my one case. I started with the local steroid injection. So he had some relief for 4 to 6 weeks. But again, he came back with severe paresthesia. That time I have to re-explore and excise the saphenous nerve. I have some photos. The nerve was entrapped inside the suture.
I operated one case, operated somewhere different city outside the state, and he came to me during lockdown that I cannot go to that doctor and now you do something. So I went inside. I just cut the release suture, the repair suture, and somehow it got released from the team.
So my question.
I don't do anything about my saphenous nerve injuries. They eventually settle down. Gabapentin.
Yeah, but
And if they're tied, I don't know.
They tell about just like teardrop or something flowing down from the medial part of the.
Because I've also seen in meniscal repairs, bucket handles, they have a burning kind of a pain every time they do extreme flexion. If we allow them to do flexion very early on, they have burning pain. So it's very difficult to know whether it is an entrapped nerve or just.
So this issue is less with a safety incision, Dr. Naresh. If you are using a safety incision, then the saphenous nerve problem will be less.
Yeah. See, if there is a safety incision, you will always be seeing a saphenous nerve. It is always safe to remove it if it is in between. Otherwise, if you are blindly pulling it out, most of the times, as Anshu sir was telling, there will be some amount of paresthesia after the ACL. So that's common. So patient will settle after some days. If it is really has problem, then we have to do something.
Sir, last question. Sir, both the cases that you have shown, the patient's profile is very thin patient, and if you encounter the very thick patient, sometimes we are not able to locate the capsules, and we are not see very nicely like we can see in here. So it is advisable to use sliding knot, or you use directly.
No, it's the opposite. If you are not using a safety incision, your surgery is much easier because you are passing the needle and the suture, and at the end you are tying it. If you're using a safety incision, the time takes is longer than without safety incision.
See, I think the analog, Pritham, is doing a safety incision, dissecting the nerve is like trying to do a big remnant preservation. You want to save the world, but by the end of it, you shave off the remnant, you take out the nerve because you want to do good, stable repairs. I think
that's what we were talking. You can't see it. It is rarely seen. Only thing whenever I have seen it during distal femur resections. It will be nearly coming in the way, and almost all the time I ended up cutting it. So, because there is no way to it will it has a very unpredictable course. It will below the knee it will be having a very much unpredictable course. However, above the knee it is relatively sure, and it will come all the time in those incisions.
We'll move to third case. So third patient, so the third case, 23-year-old male, he had ACL and lateral meniscus root tear and a medial meniscus tear. So we are focusing on the lateral meniscus root and the ACL. So this is the one. So how will you repair the lateral meniscus root with the ACL? So you will have a two different tunnel or a single tunnel. We will pass the lateral meniscus sutures to the ACL tunnel. So what? So we'll start with HS sir.
I will have two different tunnels. ACL tunnel will be different, and the lateral meniscus root
So
repair
it will be
tunnel.
anatomical lateral meniscus tunnel.
Yeah.
And Dr. Siddharth?
I'll do the same, two tunnels. But yes, literature has described that you can take the posterior lateral root through the tunnel of ACL also.
Okay. So anyone, any different thing they will do for a lateral meniscus tunnel, a root tunnel? So this is what I do. So I first do the ACL tunnel, and with that same hole from the outside, I'll put my jig, and inside it will be anatomical to the lateral meniscus root, but outside it's from the same tunnel of the ACL. So you can see this picture. I am doing the scope from outside. So that is my ACL tunnel, and that is my lateral meniscus root tunnel. And so I will tie my lateral meniscus sutures to the button of the ACL on. So there is no chance of any tunnel convergence. And with a single tunnel from outside, we can repair both lateral meniscus and the ACL. So I have a small video you can see here. Sorry. So because I use adjustable loop both on the femur and the tibial side. So once I pass my suture for the lateral meniscus root, and then I will do my ACL tibial tunnel, the standard way. So once ACL tunnel is done, now I'll put the jig for the lateral meniscus root tunnel. But my entry from the outside is from the same tibial tunnel that I have done for the ACL. So the point is same, not any different part in the cortex. So you can see clearly the two tunnel for the ACL and lateral meniscus. Then I'll pass my sutures. So this patient I used a quad tendon graft. And then now I will tie the root sutures with the ACL ABS button on.
Any advantage of doing this? Like
because you are not worried about that tunnel convergence from outside. If you are using two tunnel,
so that you
for
can
ACL,
It's a purposeful tunnel convergence, Dr. Preetham.
And the
that
second
you can
thing
check
is
with the ACL tunnel itself. You're putting the
and you can tie the suture with
Anshu
the
is
same
master
button.
in that, putting the scope into the tunnels and looking through.
We save on the buttons, sir. We save on the button.
So this technique is described in literature. It's not new.
Sir is always worried about the poor patient.
I think a small trick is to just make an entry, the tunnel entry for ACL bit medial and for a lateral meniscus bit lateral.
Yeah. That we can do. Yes. I was initially doing that only, but I shifted to this.
I think Andreas Imhoff from Germany has demonstrated clearly over last 20 years, it does not matter whether you do pass the sutures through the ACL tunnel or do independent tunnel drilling. It does not matter.
No, but I think this is easy. What he's doing, no?
Yeah, exactly.
He's keeping it anatomical.
So doing all three ways is the same. Point is you should not leave them as it is.
No, but when we want to make two different tunnels, we do a lot of calculations. We alter the course of the tunnel. So this is easier.
So last case. So this is medial meniscus complex tear. So just watch the video. How many of you repair it and how many of you exercise it? So please raise your hand who will repair it.
I would like to know the age of the patient and the occupation and the his requirement from his knee.
Patient is 36-year-old and he had a trauma 3 years back. It's post-traumatic and he has locking and pain.
My question is the meniscectomy bad operation in the correct indication? That
Sorry,
is
sir?
my question to you. Is the meniscectomy is a bad operation for the cases like this?
No, it's not a bad operation.
Yeah, I have seen even my 3 orthopedic colleagues who are now 70 plus, they were operated by Dr. Nan Joshi 40 years back. They are still very good and they are doing well. So whenever you feel this type of meniscus is there and you do the repair, all kinds of repair, put lot of devices, most of them, 90% of them, they fail.
Yes.
So therefore, I would do the meniscectomy in this case.
So we should try to repair as much as possible. That is repairable. So this meniscus seems it's irreparable. So first, it has two components. One is the flap component, the zone 3, and a horizontal cleavage component in zone 1, 2. So what we'll start with is a partial meniscectomy and balancing. Then we'll decide that it's repairable or not. So that is my first step in such cases. Sorry?
Another HS sir, a lot of people from your generation, Maheshwari sir, have done and recommended that we go for a meniscectomy whenever we feel like, whenever we think the tissue is not good, and they've done tons of meniscectomies. Is there any predictive way to understand which will go into arthritis faster? Because some people come back very soon with total meniscectomy. They come back like in a couple of years with medial compartment pain. So do you have any way to understand which patient will go into arthritis faster?
That depends on the patient prototype, the patient morphology, the type of the job or the occupation or the sport the patient is pursuing. What was the stage of cartilage the patient was having at the time of operation? So the meniscectomy does not mean a kind of total meniscectomy. It is the unstable meniscus which you are going to remove. So like when I have done the total meniscectomy when the arthroscope was not there. The Smiley knives were there and you were rather blind and going in the knee and taking out the meniscus and thinking that you have done a great job. From, last 26, 27 years I am into the arthroscopy, then I realized the importance of meniscus. The meniscectomy, that is why I asked Dr. Preetham regarding whether the meniscectomy is really a bad operation. It's
So
not a
now
bad
you will
operation.
repair it or not?
Yeah.
At present,
This horizontal component I will repair, but all the unstable component,
yes, we have to remove
which
it.
has almost separated and a kind of dismembered, I will definitely take it out.
That
I will
definitely we have
not
to
go
remove
for
it.
the kind of piecemeal repair and then wait for the healing, because this patient is not going to heal most of the time,
Yes.
and the patient will come back for the research.
So Dr. Siddharth, how will you proceed now?
I'm just surprising, like looking at the condition of meniscus. What is the condition of cartilage? Like
Cartilage is good.
completely wrong. But this kind of, it's looking like an old meniscus tear. It's not looking very recent or acute one. And if the cartilage is good, definitely I'll repair this.
So how will you repair this one?
But before that, I'll just take a scanogram also, like just to
Patient
see the
alignment is
things.
neutral.
Alignment was good. So repair the horizontal one with the scorpion or with the threads, and definitely I'll check that whether it is on the capsular part it is stable or not, and then I will repair one or two all inside.
Yeah. So this is the way we repair this horizontal cleavage tear. We call it circumferential compression stitch. So with a scorpion device, with a 2-0 suture, we'll pass multiple bites and we will then repair it.
And this is again a definite case of fibrin clot. Like if you can put
Yeah,
fibrin clot
it's
there.
better to put a clot or I did microfracture in this patient. I always do microfracture. Sometimes I use clot.
This was the case with the ACL itself.
No, this is only meniscus one. That lateral meniscus root tear was with ACL. This is isolated medial meniscus tear. So sir, we'll stop. So thank you, panels.
So thank you, Dr. Preetham and Dr. Suneet, for wonderful panel discussion. I think all your queries about meniscus tear and repairs are now sorted out. If anything left, you can ask them during lunch. Meanwhile, our live surgery is ready. So I will just tell about little bit about the case. She is a young female, 34-year female. She had a history of twisting injury due to fall from two-wheeler 2 months back. She came to me with complaint of pain and instability. Her left knee is involved. On examination, the signs for the ACL anterior drawer latchman is positive. Pivot shift was grade 1, not so significant. Posterior drawer negative. Range was full. The knee was silent. There was no swelling. Valgus stress for MCL was grade 2. There was a physiological lateral laxity which was in both the knees, and there was a medial joint line tenderness. I expected to be a meniscus tear, but somehow in the MRI it was normal. So I did a scanogram, which I routinely do. The scanogram was totally normal. There was no limb alignment disturbances. Her valgus stress was showing a grade 2 opening. However, the varus stress also was physiological positive, but we are not going to deal with that. The physiological lateral laxity. Her MRI, which showed a complete ACL tear. The PCL was, however, normal but buckled due to the absent ACL. In this, you can see the normal PCL without an ACL. On coronal sections, you can see there is a complete tear of MCL from tibial attachment. The superficial and deep both components were torn. Here you can see there is a complete laxity. Grade 2 was probably because of the fibrosis which occurred later on. So we are going to see. So the diagnosis of that patient is 34-year female with left knee complete ACL tear and almost complete MCL tear. So now for the live surgery, to moderate the live surgery, I would like to invite Dr. G.S. Asati sir and Dr. Anshu Shekhar. Dr. Anshu, I think he has gone to Chaat Bhandar, eating some chaat like yesterday. Sir, you can sit over there. Live stream connect. Meanwhile, Anshu came after eating her chaat from Mathuravasi. Now you have to moderate the session with Asati sir, Anshu. The patient is a complete ACL tear with MCL tear. Jadhav sir is live. Sir, you are live, and Anshu and Asati sir are online. Jadhav sir, can you hear me? Audio. वहाँ का audio. There is an intro of finding of a medial meniscus tear, which you can see.
Hello.
Jaro sir, you can hear me? Jaro sir, you can hear? You can hear me? Yes, we can hear you. We have Anshu and Asati sir for you to moderate the surgery.
Sir, Jadhav sir, can you hear us? Yeah, I can hear you, sir. You are well audible here.
We can start with the diagnostic just come back to it in a minute. But what we have found is maybe has anterior horn and body of the lateral meniscus there. Okay. So if you can see, I have put in one wrap around all inside 6 here. That's your popliteus tendon. That is posterior. And then we are into the anterior part of the body and anterior horn. Okay. I will just come from the anteromedial portal that will give us a little bit of better idea of what we have inside. Yeah. Okay. So that is our lateral meniscus, which was come from here, that is anterior part of the body, and then we have put in about 3 outside in sutures. This is one, I have not yet tied it. Is it complex? Yeah. So that's the tear which was there. Yeah. So if you can appreciate it, don't pull on the thread. Yeah. So that is one, that is two, and that is 3 outside in sutures we have put in. And I have put in one wraparound all inside suture. So that is like an anterior horn and body part, anterior part of the body tear. So we have just repaired it, and then we'll come back to other diagnostic findings. Okay. Okay. So she has femoral sided ACL tear. So femoral sided ACL tear, or TBL stump is intact. So kind of abrasion, you can call it as a German type 2 kind of injury. Okay. So most of the ACL is intact here, but it is avulsed from the femoral side, and that is empty, not been there. Okay, so we are just trying to preserve all these things, and if you can, do a remnant preservation, ACL reconstruction, keeping all this stump intact. Let us see how it goes. Another striking feature is we are not really into the valgus vein. Still, we have a very good, I would say, grade 3 medial sided opening. Okay, that's medial meniscus. Medial meniscus per se looks normal. We have gone inside on the ramp side also. Everything looks good on this side. Okay, as far as this. So what you can see is some of the MCL and posterior capsule is torn from the tibial side. The MRI findings show the same thing. We have a tibial sided MCL injury. So this is consistent with this. So our plan is to do a remnant preservation ACL reconstruction, and then follow it up with MCL reconstruction. And she's going to require both superficial MCL as well as POL reconstruction because her clinical examination under anesthesia was showing quite a bit of opening in full extension as well as 30 degrees of flexion. What does that tell me? That she has a button to pass on.
Right, sir.
Okay. So I'm hoping that our tunnel should be more than 30, but it really doesn't matter if you're using so-called
Adjustable loop device.
adjustable loop. So
Yeah.
I'm just 30, so I hit the cortex. So this particular thing is about just more than 35 in. Yeah, about maybe 36 or 38, and that's good enough length for me to work on. So I'll drill about 20 millimeters with the diameter of the graft, and that is in this case about 8 millimeters. Okay. In our population, females getting 8 millimeters of hamstring or maybe 6-strand hamstring, sometimes you cannot get 8 millimeters. So it's good that we have a peroneus longus, which is about 8 millimeters here.
Sir, before you drill this, sir, can we just have a look at the view that you have achieved from the anteromedial side?
Yes, I will.
I mean, yeah.
Any significant benefits of remnant preservation? Your
Theoretically, yes.
what? Proprioception.
Yeah.
because it depends upon the number of ACLs any surgeon is doing.
Yes.
If the person is doing less number,
Yeah.
I will advise not to preserve.
100%.
It will compromise the view.
Yes.
Why unnecessary?
That's the view from the anteromedial portrait.
Yeah. Yes. Yes.
We are
Yes.
just behind the so-called residence ring.
Yeah, you are within the footprint area. Yeah.
Within the footprint. Yeah, that is one of the advantages of using this particular accessory anteromedial portal.
Yeah.
Drilling.
And your viewing is now from the standard anteromedial portal. That's not a Freddy Fu portal, right?
Just check how much I have gone. So I have gone about 50 millimeters. I'll make it 20 and maybe a little more than 20, so that you have an option of having a graph which you can tighten it at the end of the
Retensioning.
retention. Yeah, once you do the tibial fixation, and then you can clear this. Clear the. See, this looks little weird because we have not taken out any of the stump.
Yeah.
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 So that's the posterior
Yeah,
wall
this is
structure
perfect.
like that,
Yes, yes.
About 2 millimeters.
Yeah.
We should have about 2 millimeters of the posterior wall.
Right.
Otherwise, we'll end up having blowing out the posterior wall. And to some people, even if you are blowing out the posterior wall with this kind of button fixation is okay, but it is always better to have a good posterior wall which is intact. Yeah.
Yes.
I'll just pass the passing suture and I'll park it, and then we'll move towards the tibial side preparation.
Yeah. नीमा सर ऑलरेडी वो स्टंप का अभी खिचड़ी बनने लग रहा है. वो by the end of it, it will become keema.
No, that's what I said.
Yeah.
There is no benefit actually. Patients do not regain any sort of proprioception. Rather, it increases the surgeon's, I will say, compromise to the view. not, not ego, but
It's not ego also. There are
ego,
some evidence
but
showing that you can have a good proprioception fibers into that. Okay. And as a graph, what we are putting is dead collagen. Instead of dead collagen, why not have a little bit of a live collagen there? Okay, which has a blood supply to it. So there are two ways of looking at it. You have a mechanical advantage as well as the proprioception advantage. Okay?
no. I would like to add one more thing. You know, as far as the femoral tunnels are concerned, the variability in femoral tunnel placement is not too much. Whereas when we come to the tibial side, the variability is considerable. And with with an intact, yeah. Yeah. So
all the literature and everything tells you to drill the femoral tunnel in a good way, but nobody really gives that much importance to the femoral tunnel.
so that was my concern, that if we are having an intact tibial footprint, then you may have more variability in its placement than that.
That's why I said in so-called disclaimer that remnant intervention not at the cost of anatomical placement of the tunnel. In any way, I feel I am not able to put my tunnel into an anatomical position with remnant intervention. I can take this remnant out anytime. Okay?
Yeah, exactly.
Again, we go in what is the medial tibial spine, then anterior posterior border of the anterior horn of the lateral meniscus, okay, medial tibial spine, and try to find out the spot which gives me a best of all three, okay. So let me come out through this and then, okay.
I would like to ask one question at this stage. Now we have the box technique, and we make a imaginary box and take out the drilling pin. But the conventional one is 7 millimeters from the posterior cruciate ligament. That is also one more landmark. So where will you take that 7 millimeters and the flexion of the knee?
Just measure it and let you know in a minute.
Yes.
Yeah.
Sir, with this kind of footprint tamer, don't you think it is better to maybe trim down that remnant?
I feel I have an option of trimming down at any point. Okay.
Yeah.
Let me try if I'm able to do it.
Yeah.
If I'm able to do it, okay. If I can go through this remnant so that that remnant becomes kind of wrapped up against my graph. Okay.
Oh.
If I can achieve that, why not? And if I'm not having any impingement on the anterior or the lateral wall, why not? Okay, that's my take on this. Okay. My wire once it comes out, okay, and then we decide whether should be. We have a great look on this. spine. Okay, that's your lateral tibial spine. Okay, right. I am earning little bit on the medial side, and that's your posterior border of the anterior horn of the lateral meniscus. Okay, I think this point looks good to me. If everybody agrees to it, I will just go ahead and drill. What's the view?
So you do a one-step reaming or you will go sequential reaming, sir?
What I do is, if a good remnant is there, I want to have a one-step reaming, okay, so that I disturb the remnant as minimum as possible. But once I reach the subchondral bone, I will really go very slow. Yeah. And then okay. So we are on the medial side. We have kept the medial wall of the intercondyle are not intact. I kept the whole of the remnant intact. Okay, I am of the view of little bit of so-called medial cuffing that gives me a good rotational stability. That's what it is. So I have just stopped off a cartilage on the medial side, which is about millimeter or two. Okay. We are still into the area where it should be. Now, clearing the tibial side of the
So you're clearing the mouth of the tibia. Yeah.
the mouth of the tibial side so that there is no difficulty in passing the graph. Yeah, passing 38 on the yes, 38 on the yeah. So that is where it is. Yeah, we have just moved that tibial thumb on little bit on the lateral side. So if you see this, okay, that's the lateral, that's the medial. So as I told you, I am pouring little bit on the medial side that I always do it even in a normal non-remnant preservation surgery also. Okay. So on the and 20 millimeters of kernel. 38 on the
So using an adjustable loop on the femoral side.
on the femoral side.
So can we have a look at the graph?
I don't know whether you are able to see.
Yeah, we can. Yes, yes. AV, can we have outside picture bigger and scopy picture smaller, PIP?
Just mark the length of the tunnel.
Yeah.
And then we'll mark the length of the graph to be kept inside. Okay.
So this is 3-strand peroneus, sir?
3-strand peroneus.
Right.
Okay. So, yeah. So these are the markings. 38 on the loop side. So this is.
So in the pre-peroneus era, what would be your graft choice?
I would take ipsilateral semiti and gracilis if required.
Okay. No, before there was peroneus. I mean, you have been in practice much before peroneus.
An option of PTP, but not good for a female who is into her 40s. Okay.
But
so contralateral semi-T.
Okay.
Contralateral semi-T would be a good option. Yeah. So we are just passing the loop, okay, and I will be showing it to you.
Cameraman, scopy picture big, PIP small, outside PIP small. AV.
Scopy picture big, करना.
Yeah.
Click here. Click here. Yeah, click. Just a minute. I just want to see whether it is completely clicked. So that's the view of the tunnel. Okay, I'm just putting it. Just a minute. Just a minute. Okay. Yeah. Okay. So that. Somewhere there.
Yeah, looks like it is on the ITB. Yeah.
Quite hard.
Yeah.
Just a minute. Let me give another 5 minutes to this to it. Okay. I just wanted to see whether we are not into the substitution. Okay. Can you give me a minute? So, we are into the substitution.
So this is the big problem with using adjustable loops. Correct, sir? Yeah.
This is the big problem in the light circuit.
Oh.
No,
That's
another
another thing.
Yeah.
another question is
So I will
compared to the fixed loops
yeah,
versus the
I am still,
adjustable loops,
I still
has there been a more demonstrable more than 5 millimeter displacements during arthrometer testing?
No.
No? Sure. Because the failures with the adjustable loop are reportedly more as compared.
That is because unfortunately we are using all sorts of nonsensical adjustable loops. If you're using an adjustable loop, it should be a good adjustable loop, or you open it laterally and tie sliding knots.
Now, another of my question is,
Yes.
given
Yes.
given an option between the loop versus the screw,
Yeah.
what you will choose?
100% loop.
Why?
Two reasons. Number one,
now I am
let him finish.
It's okay. So that gives me confidence that okay, we have the
I believe because of ease,
No, no,
not
no.
because of science.
Science. It is a science, sir. Yeah.
going on, right?
So I think no. So I think the two reasons are, this is I'm talking with respect to soft tissue grafts. Number one, soft tissue heals at the mouth. If you put in screw, you are compromising 30% of the surface area with your screw. So your healing is going to be only on 70%. So that is compromised biology. Second, the fixation strength on the femur with a cortical fixation is far superior to aperture fixation. For a BPTB, it is definitely aperture fixation. But for a soft tissue graft, cortical fixation is known to be superior. Even if you look at the Swedish ligament registry and even the Nordic ligament registry, the least failure rates are with a combination of fixed loop with titanium screw in the femur, in the tibia.
No, because the healing of the graft will be at mouth. Whatever modality you use the suspensory loop or you use the interference fit. The healing will be at the mouth, and
Correct.
that is the analogy behind 15 millimeters of length.
Yes.
Okay. So when you are using a screw, almost all of the systematic reviews also have demonstrated that that is a superior method of the aperture fixation is the superior method of fixation.
Not for soft tissue grafts. For BPTB, yes. Not for soft tissue grafts. For soft tissue grafts,
I'll revise my literature review. Again.
soft tissue graft healing if you look at even the ANZ registry, the Australian New Zealand registry, and the Swedish ligament registry, best outcomes are with fixed loop on the femur and titanium screws on the tibia, which is like Ayushman package. Okay, can we have a show of hands as to how many of you are still using fixed loops, not for financial reasons, but you believe in fixed loops for everything, ACL, PCL. क्या है sir? Either the tip is there or tip is cut off.
So, we are able to bring that loop on the femoral cortex. Okay.
Right.
Yeah. Right.
Sir, so you expose laterally and the button is on the ITB, is it?
Mm-hmm. Yeah, button was like because it is pulled out.
Huh,
Button was on the ITB.
yeah.
Yeah.
So do you like to put your scope in the anteromedial portal? Always have this tunnel in tunnel view when the button is exiting.
Before I
Yeah.
could do it.
Yeah, it was pulled. Yeah.
Yeah, he just pulled it out.
Yes,
Okay,
yes,
that's
yes.
okay. Yeah.
Yeah, now it's back.
Now
Yeah, now it's back.
feel my button exactly on the cortex. Okay.
Oh.
And there is no soft tissue.
Yes.
Kind of feel here. Okay.
Yes,
Which
yes.
was there previously. Yeah.
Yeah. नीमा सर, look at the remnant.
इसको समझना बहुत मुश्किल है. Adjustable loop.
Okay, so we are just pass the craft on the femoral side.
Camera person, can we have the outside picture big? Scopy picture, PIP small.
So that is it. And then I will just revisit it once I have fixed on the femur arterial side. And if this is not impinging, I'm going to keep it here.
Yeah.
If I want, I can just remove this superior part of it.
Yeah.
Okay, but that gives me a good envelope of the tissue. Okay.
Yeah.
And which I think theoretically at least has some advantage to it. Okay.
Barabar.
Yes. Give me a screw. We just cycle it.
So what screw are you using and what size?
I use 1 millimeter up, okay, and 30 millimeters. So this is 9 by 30 for the 8 graph.
Okay. That's a peak or bio?
This one is bio.
Okay.
This one is peak. This one is peak, sorry.
Okay.
But I do use bio composite.
And what's your fixation angle going to be?
It is going to be about 20 to 30 degrees of flexion. Yeah.
Okay.
Little bit of a posterior traverse given to it.
So do you adjust your fixation angle based on patient characteristics, or is it always 20-30 degrees flexion?
This is always about 25 to 30.
Okay. Even if the patient has hyperextension or hyperlaxity?
That I will then fix it in a, I would say, near full extension.
Okay.
Okay.
Right, sir.
With some of the recent use of so-called synthetic ligaments, they also recommended to fix it on in full extension. Okay. All right. So to me,
AV arthroscopy picture big?
How are we on time?
So I think you.
How much time I have for MPL?
sir. Sir, at about 20 minutes or so. Chalil ka?
Okay, so I will just expose it.
Yeah.
Just mark the tunnel maybe.
Okay.
Then if it is going to be too late.
Okay.
Then you can start with something.
सर मग तुम्ही डिसेक्शन करून घ्या सर. तो सर वी विल फिनिश आवर इनॉग्रेशन आणि येतो विल बॅक. हो. Okay. AV, can we have the arthroscopy picture big? Sir, can you just show this stump status now? Arthroscopy picture big, please. AV, how? Yeah. हाँ सर. नहीं नहीं.
I have not, at least what I've done is I have not got compromised on the penetration aspect. Okay.
हाँ. Sir, Jadhav sir. So we will mute you. We will keep seeing what is going on by the time we are having our inauguration. Just one last question. Do you believe in suturing this ACL to the stump? I mean, graft to the stump.
Sometimes I do take a kind of baseball kind of suture through this.
बरोबर.
I will take this sutured threads to within the button which I am used here, and I tie knot on the lateral femoral cortex. I have quite a few cases of this. Okay.
Right, sir.
That is kind of an augmentation. Instead of suturing, I prefer this technique. Okay.
Yeah.
So that you have a good hold from the base of the ACL, right?
Yeah.
And then you can tension it accordingly how much you want it.
Yes. Yes. Yeah. Okay, sir. So we'll keep.
Guys continue.
Yes.
I will just come back to you once I am done with my.
Yeah. Okay, sir.
So this ACL and meniscus part of the live surgery has been finished, and sir is meantime getting ready with an MCL reconstruction part. Till that time, we will do an inauguration ceremony of this conference. For that, for the inauguration, I would like to invite Dr. Dheer sir, Dr. Lal Chandani sir, Dr. Vinod Tiwari sir, HS Agrawal sir, Suman sir. Sir, can you please come on the dais for lamp lighting ceremony and Saraswati Vandana? Prashant Dwivedi sir, please. Ashish Mundra sir, where are you? Ashish Mundra sir is here.
या कुन्देन्दुतुषा
आशीष मुंद्रा सर हैं क्या? नहीं है. So after this lamp lighting ceremony, I would like to play a message from the President of Indian Arthroscopic Society, Dr. Sundarajan sir. Please, can we have that message video? First video.
Things from Indian Arthroscopy Society. And please accept my apologies for not being in person due to multiple programs across the India. And I want to proudly say that Indian Arthroscopy Society has got almost 5,000 members. That means 5,000 sports surgeons across India, one of the largest society around the world. So we can be proud of that. And my presental theme is joint preservation, that is to repair, reconstruct, and restore the joint. We don't treat as a ACL surgery alone or a meniscal surgery alone. We treat the patient at the same time. We treat as a joint, and so that we can reconstruct the joint to delay the arthritis or delay or postpone the replacement in the future. I'm sure that these kind of programs will help us to understand all about ligaments, cartilage, as well as the alignment, so that you can restore the joint for this patient to get back to their normal life. And I take this opportunity to thank organizers for arranging this program and esteemed faculty who traveled across the India to teach you and share you and to help you to get upgrade your knowledge in arthroscopy. It's a great opportunity for all of you at the same time to become a member of Indian Arthroscopy Society, so that you can avail a lot of fellowships. You can get a lot of large knowledge from our website, which constitutes hundreds of webinars, surgical techniques. So please become a member of Indian Arthroscopy Society. Once again, I congratulate all the organizers of this course. At the same time, best wishes for all of you. Thank you very much. Greetings from Indian Arthroscopy Society.
Now,
and please accept my apologies for not being in person.
Yeah. Now we have a information video about Indian Ligament Registry. Can we have next video?
We all know that the number of ligament surgeries being done in this country outnumber that in many other parts of the world. I think this registry will help us understand the trends of ligament surgeries that are happening in India and help us in bettering our outcomes in the long run. The Indian Ligament Registry will help Indian surgeons showcase their work on the world stage. Dr. Armugam and his team needs to be complimented for the exemplary work that they have done for the Indian Arthroscopy Society. By setting up the ligament registry, I think they have notched up the game by a couple of points. I again compliment the IAS for setting up the Indian ligament registry.
till the time our next part of that live surgery is getting ready, we'll move ahead to session 3. To moderate the session 3, I would like to invite Dr. Pramod Jaiswal, sir. Yeah, you are here. I would like to invite Asati sir is there. Dr. N.K. Trivedi, sir. Sir, can you please come forward? Trivedi, sir. Trivedi, sir, can you please come forward? I would like to ask Dr. Shirish Mishra, sir. Please come. Just Shirish Mishra, sir. And and we have from Korba Medical College, Dr. Deepak. Dr. Deepak Ditlare, can you please come to chair the session? Yeah, please come. आप अभी साइड में हो सकते, साइड में बैठे रहो. आपको लाइव सर्जरी में आप वापस आ जाना. प्ले कर दो. Can you play that membership drive slide? प्ले करो ना. अच्छा, okay. I would like to invite Dr. Samir Mittal for his lecture on approach to an acute knee dislocation. Dr. Samir? Yeah, please.
A very good afternoon, everyone. My topic is an approach to acute knee dislocation. Knee dislocation is a usually high injury traumatic injuries with high rate of neurovascular injury. It's a rare kind of injury with 0.02% of all the orthopedic injuries. But this incidence is likely underreported as approximately 50% of injuries self-reduced and are misdiagnosed. Popliteal artery injury usually occurs due to tethering of the popliteal fossa at proximal end. It passes between the fibrous tunnel at adductor hiatus, and at distal end it passes through the fibrous tunnel at soleus. Geniculate arteries, they provide collateral flow and palpable pulses masking limb-threatening injuries. This is a slide where we can see there is a many geniculate arteries which can mask the popliteal artery injury. Then classification, first is the Kennedy classification. It is based on direction. It is based on direction of displacement of the tibia. Most common is the anterior knee dislocation. Most common due to hyperextension injury involves tear of PCL. An arterial injury, intimal tear due to traction of the highest rate of peroneal injury. Next. Posterior, it is second most common due to axial load to flexed knee, highest rate of vascular injury, highest incidence of complete tear of popliteal artery. Lateral 13% due to varus or valgus force involved tear of ACL and PCL. Medial 3% varus or valgus force disrupted PCL and PLC. Then rotational knee dislocation usually irreducible. Posterolateral is the most common rotational dislocation. Buttonholing of the femoral condyle through the capsule. Then Schenck classification, it is based on number of ruptured ligaments. KD1, This multiligamentous injury with involvement of either ACL and PCL. KD2, injury to ACL and PCL only. KD3, injury to ACL, PCL and posteromedial corner, or PLC, 3 ligaments. There are 2 types, KD3M, ACL, PCL and MCL, and KD3L, ACL, PCL, PLC, LCL. KD3M has highest rate of vascular injury, 31%, based on SENG classification. KD4, injury to all ACL, PCL, PMC and PLC. KD5, multiligamentous injury with periarticular fractures. Presentation, symptoms, the history of trauma, knee pain, knee instability. In physical examination, sometimes there is no obvious deformity because 50% of spontaneously reduced, therefore are underdiagnosed, may present with subtle signs of trauma. Obvious deformity may be there. If there is obvious deformity, we should reduce it immediately if the pulses are absent. Dimple sign we should watch. There is buttonholing of medial femoral condyle through the medial capsule. Indicates an irreducible posterolateral dislocation. It is a contraindication to closed reduction due to high risk of skin necrosis. Vascular examination, this is the most important part of acute knee dislocation. We should rule out vascular injury before and after reduction. Do serial exams, palpate dorsalis pedis and posterior tibial artery on both injured and contralateral limbs. If pulses are present and the normal, it does not indicate absence of arterial injury. Collateral circulation can mask on complete popliteal artery occlusion. We should measure ankle brachial index in all the patient. This is a diagram of measuring ankle brachial index. We should measure ankle blood pressure and brachial blood pressure. And if the ankle brachial index is more than 9, we should monitor the patient with serial exams. If ABI is less than 9, we do arterial duplex ultrasound or CT scan angiography. If no arterial injury is seen, consult a vascular surgeon. If pulses are diminished or absent, confirm that the joint is reduced, and if not, reduce it and reassess. If pulses are still absent after reduction, immediate surgical intervention is indicated. Ischemia of more than 8 hours increases the amputation rate by up to 86%. Imaging is contraindicated if it will delay the surgical revascularization. If pulses are present after reduction, do ABI. Then, depending on results, consider observing or imaging. Neurological examination, you should assess sensory and motor function of peroneal and tibial nerves. We should assess the stability. This is the picture of hyperextension after the knee dislocation. We should image the patient pre-reduction AP and lateral view of the knees are important, and post-reduction AP and lateral views should be done again. This is an X-ray of posterior dislocation of knee. CT scan is indicated if there is a fracture. MRI indications obtained after acute reduction but prior to hardware placement to evaluate the soft tissue injury, ligamentous, meniscus, and for surgical planning. Treatment non-operative, emergent closed reduction, then vascular assessment is indicated. Immobilization as definitive management, it is usually not recommended because most cases require some form of surgical stabilization following reduction. Outcomes are worse than those of operative management. Prolonged limb immobilization may lead to loss of range of motion with persistent instability. Operative management, open reduction, indications are irreducible knee, vascular injury, open fracture dislocation, obesity, and posterolateral dislocation. External fixation, indications are open fracture, vascular repair, compartment syndrome, obesity, and polytrauma patients. Delayed ligamentous reconstruction, indications are instability. Patients should be placed in a knee immobilizer until treated operatively. Improved outcomes are seen with early treatment. Sweet spot is 1 to 3 weeks. Complications are vascular compromise, 5 to 15% of knee dislocation with up to 50% of posterior dislocation. Risk factors are KD4 injuries, stiffness, arthrofibrosis may be there, laxity and stability. and peroneal nerve injury. Thank you.
Thank you, Dr. Samir. Now I would like to invite Dr. Sandeep Nema sir from AIMS Raipur for his talk on approach to chronic knee dislocation.
Good afternoon all. Greetings from AIMS Raipur. मुझे जब अभिषेक ने ये टाइटल दिया टू स्पीक अबाउट क्रॉनिक नी डिसलोकेशन, तो मैंने अपने पुराने जो एक्सपीरियंस थे उनको रिवाइंड किया कि मैं सबसे ज़्यादा कहाँ कंफ्यूज होता था, और मेरी जो टारगेट ऑडियंस है वो मोस्टली यंग ऑर्थोपेडिक सर्जन्स होंगी, तो वो कहाँ कंफ्यूज होंगी. अचीव्ड इन माय प्रेजेंटेशन दैट इज गुड इनफ फॉर मी, and that is my target. I will not be speaking about chronic knee dislocation, but what are these two terms? MLKI, knee dislocation, are the same? And let us see. So I took the help of Dr. Pardiwala's two papers, one published in Journal of Knee Surgery and second is in the IJO, and then subsequently used some of my AI help and some of my own experience to synthesize this lecture. So chronic knee injuries, setting the record straight, a clinician's guide to distinguish managing chronic multiple, it's changing by its own, okay, multiple ligament knee injury versus chronic unreduced knee dislocations. So why clinicians confuse is because both involve knee, both are chronic. Knee dislocation and multi-ligamentous knee injury both involve the knee, both are chronic, and both have ligamentous laxity. Now, what are the differences between the two? Because chronic unreduced knee dislocation, clinicians will see 2 or 3 times in their lifetime. Okay? Because itne lambe samay tak usually patient will approach some clinician, but they will see less compared to multi-ligamentous knee injury, which are very frequent. Now, so what is chronic MLKI? Disruption of 2 or major knee ligaments. Knee joint is reduced spontaneously or formally. It is reduced. It will not be visible as a dislocated knee. Second is patient is ambulatory. Patient will be moving, okay? May have abnormal or normal limb malalignment or limb alignment. And chronicity is defined greater than 6 weeks from injury and most common missed because it is spontaneously reduced. 2 types have been described. One is acute high velocity trauma, where you will be having a knee dislocation, knee multi-ligamentous knee injury. Sorry, I am using this interchangeable word, but you'll have multi-ligamentous knee injury consequent to a high velocity trauma. Second will be obese patients, where you will be having a multi-ligamentous knee injury, and that will relocate in place and patients will be walking. They will have symptoms of instability. They may have malalignment on X-ray. That is what is, I will say, as MLKI. Now, what is a chronic knee dislocation? That is, a knee joint remains unreduced, tibiofemoral. Duration is 1 month to 6 months. Patient has a fixed deformity, not merely unstable. It will be having a fixed deformity. Gross stiffness plus instability. Then causes include polytrauma, which is missed, post-op neglect, obesity. So recently we had a patient was having a concomitant femur fracture with a dislocated knee. So some 6 months or 7 months old. Was plated elsewhere, sustained non-union because patient was not walking, and then subsequently we had to intervene. So that is what is the difference between. तो आप सिंपल ये याद रखें कि chronic knee dislocation का patient चलता हुआ नहीं आएगा, whereas MLKI multi ligamentous knee injury का patient चलता हुआ आएगा. That's good enough to differentiate between the two.